Welcome to the session, What I Did Differently. This is a session of masters in ophthalmic practice, mostly surgical techniques which they did in the last year, either as a new technique which they devised or as a compulsion for something else. So all these are masters in the respective fields. I would request all the participants, Dr. Elizabeth, Dr. Mahesh, Dr. Satyan, Dr. Jason, and Dr. Marian to come and join me on the stage here. We'll start off this session with Dr. Elizabeth Joseph. She'll be talking on silicon band belting on vertical recti in lateral rectus palsy. As you know, Dr. Elizabeth Joseph is the senior most strabismus surgeon in Kerala. She is the head of the Department of Ophthalmology at Little Flower Hospital, Angamali. Over to you, Elizabeth, ma'am.
Good morning, everyone. What I did differently. I thank Dr. Thomas Cherian for including me in this symposium. This is about silicon band belting of the vertical recti in lateral rectus palsy. This is a very new technique and very rarely done. And this is a patient who presented with right lateral rectus palsy. You can see that there is a large esotropia of the right eye due to medial rectus contracture and complete absence of abduction. You can see in the one picture the patient is trying to look towards the right side, but the right eye is not moving at all. Right eye is fully convergent. There is no lateral rectus movement. There is medial rectus contracture. In such huge medial rectus contracture and huge esotropia, the current surgical options are large medial rectus recession with vertical rectus transposition to the lateral rectus, either full transposition or partial transposition, or Nishita's transposition. These two procedures have got limited success in large abduction deficit, and also a full vertical rectus transposition along with a medial rectus recession can produce anterior segment ischemia because it will affect the vascular supply of the anterior segment of the globe. So I thought differently, and I heard about this technique of new technique of medial rectus recession with silicon band belting of superior rectus and inferior rectus. The principle is to place a silicon band around the lateral halves of superior rectus and inferior rectus to change the force vector of the vertical recti. The silicon tube will act as a sling to maintain alignment in the primary position. I'll show you the surgical video. First, we have to do the force duction test, make sure that the eye is not abducting, and this you can see the medial rectus is recessed. After recessing the medial rectus, by supratemporal and infratemporal incisions, we isolate the superior rectus. Now this is the superior rectus muscle visible, and I am trying to split the superior rectus muscle into medial and lateral halves. After splitting the superior rectus, I will put a silicon band through the lateral half of the superior rectus. You can see the silicon band, 240 silicon band which the retinal surgeons use. That is the same thing which we can use. And you put the silicon band and pull the lateral half of the superior rectus laterally. Now the sling is passed underneath the lateral rectus muscle and is passed through the lateral half of the inferior rectus. So both the inferior rectus and the superior rectus lateral halves are pulled laterally to make the eye in the primary. By pulling on the silicon band, you can pull the eye laterally, and once the eye is in the lateral position, is in the primary position, you can suture the silicon band with a non-absorbable suture, and this suture can be buried, and this node can be placed underneath the lateral rectus, so it is not cosmetically a problem. And after suturing the silicon band, you can test the tension on the band and see that there is no extra pressure on the globe. It should not affect the vascular supply of the globe. So there should not be any pressure on the globe, but the eye should come towards the primary position. After the silicon band is in position, you can close the conjunctiva. That is the procedure. So this will produce an abduction force to the vertical muscle. And You can see the preoperative picture. On the right hand side, there is a huge esotropia with abduction defect, and the postoperative picture taken 2 weeks later, you can see that the eye is in the primary position, and you can see that the abduction has improved. So this patient, she got relieved of her diplopia and the cosmetic problem. Primary position diplopia is gone, and I found that this is a very good surgical procedure. So silicone band belting is a good procedure in LR palsy with MR contracture and -5 abduction deficit. Thank you.
Thank you, madam. Do you have a long-term follow-up for these patients?
Yeah, this was done last year. More than 1 year follow-up is there. One complication you can expect is extrusion of the band, but that has never happened, and there is no pain or irritation. Cosmetically, it's good.
Because bands are expected to stay for a lifetime when we do it for a retinal surgery, but the only difference is there you keep it snug to the sclera, while here you are attaching the muscles. That means it's more superficial.
Yeah. The only risk is expulsion, but it has not happened. I can bury it under the lateral rectus muscle.
Okay.
Did you anchor it to the sclera, madam? Yeah, I didn't.
No, I didn't anchor it to the sclera. If you anchor it, then the muscle force may not act well. You are just putting it through the superior rectus and inferior rectus and passed it underneath the lateral rectus muscle.
Because some of our old buckles, they can intrude through the muscle, cut through the muscle, and then come migrate anteriorly.
That depends on the tension on the silicon band. The silicon band tension should be adequate, should be correct.
Like in our belt buckle, we put around for RD. We can, if it is anchored, probably the muscle transmission force will be different then.
That depends on on the tightness.
And what suture did you use, ma'am?
Non-absorbable suture 50.
Any questions from the floor? Thank you, madam.
Thank you. Thank you very much.
From screen, we go to retina, and here we have Dr. Mahesh, the dynamic young president of KSOS and renowned vitreoretinal surgeon from Cochin. He'll speak to us on expanding horizons in resurgery after diabetic vitrectomy.
Thank you, Dr. Thomas. So, what did I do differently this year? Actually, this is not this year. In the last probably few months or few years, I have been trying. See, our main patients are diabetic retinopathy patients for a VR surgeon, and many cases we fail due to the pathology of the disease. We are fighting against ischemic retina. Many times we do vitrectomy, then it comes back, we do TRD, it will not settle all ischemic retina, sclerosed vessels. So these sort of cases we try once and then leave it. Most of the patients will become no PL in the course of the time if the surgery fails. That is the problem with PDR. So last 1 year I have started reoperating this one more time, and some of them have given good result. Like this was a patient this patient, this was had a recurrent vitreous hemorrhage. In fact, other eye is NVG, no PL. So since it was recurrent vitreous hemorrhage with 1 or 2 meter, I did posted for a vitrectomy, and as usual, we tried to induce PVD with the cutter itself. It was a very adherent vitreous. Then cauterize the bleeding points, give good laser. It's a clean surgery, so there was no bleeding at the end of the surgery. So just put air and stop it. So this is just a vitrectomy, membrane peeling, endolaser, and this was the result. 1 month he was doing well. He started reading 618, N8 and all. Then it redetached again. Then I took the patient again. Initially I thought it's a bad case, we will leave it. But since it is one-eyed, I took it again. Then I had a hell of a time inside the eye, because there was a complete sheet of membrane within 1 month proliferating across the retina. So this is that, and that too, that membrane was something like a rubbery, cheesy sort of. It is coming piecemeal like this, and the importance of peeling is shown in this video. Complete removal, and from arcade to arcade there was membrane. So it was peeled like this throughout. Luckily, there was no bleeding during the surgery since it's already very well lasered. So till the periphery, till the vitreous base, it was separated. Then it was removed with cutter, and without much of a problem, I could separate without much of a iatrogenic break creation also. And decided that since it is one-eyed and recurring problems like this, we thought we'll put oil after a good laser. So this is the final membranes peeled in the periphery. So basically, this is an anterior hyaloid proliferation or even pan-hyaloid proliferation with membrane proliferation under the post-vitrectomy. So did the FAE, gave laser, it was quite good, and then gave laser like this to the fill-in laser, and then put silicone oil. So this is injection of silicone oil, retina is attached. And at the end of the surgery, post-operatively, he was doing well. I was expecting whether he is going into NVG, but he did well with around 6/36 and 36 sort of vision, and he is maintaining for the past 6 months. So this is the importance of resurgery in PDR failed cases, especially reproliferations. So I feel especially in one-eyed patients and all, if you are doing this, can salvage some vision. So that is just, thank you.
Thank you, Mahesh. Please stay there. The key to a failed vitreoretinal surgery, be it in diabetic or even in a rheumatogenious RD, is almost always a membrane. So always go and search for a membrane if you have a recurrence. It should be there somewhere. It's not due to a fresh break. It could be a secondary break, but it's almost always a membrane, and search for it. The second dictum, your first surgery, you might go without an air, with gas, but if there is a recurrence, better to go for oil. So I feel that is the message that Mahesh has given.
Yeah, and you have to keep trying, especially in cases like this, even though the prognosis may not be always good. So that is, this patient is quite happy ambulatory. So that is one thing.
Yeah, and here again, the prognosis doesn't mean he is going to read 6/6.
Yeah, that's what. 660 is inadequate for his daily.
That should be very clear on the surgeon's part as well as on the patient's part, that what we are striving for is to attain this navigable vision.
Thank you.
Thank you, Mahesh. So let's go to our next master, that's Dr. Satyan. He's a renowned glaucoma surgeon. He's the president of the Glaucoma Society of India. Dr. Satyan will speak to us on YAG-PI without pilocar.
First of all, my sincere thanks, and always been a pleasure to be in KSOS meetings. How many of you do YAG-PI here? Can you just raise your hands? Oh, that's wonderful. Then my talk is really fulfilled. So how many of you do use pilocarpine? So all of you are getting pilocarpine. How many of you are not getting pilocarpine? Okay. So how many of you have the problem of patient complaining, or probably many times we don't even ask whether the patient has a problem or not. Do you ever ask whether the patient has a headache after applying pilocarpine? Okay, only one of those. Okay. So definitely most of the patients, they do have a headache with the pilocarpine application, or they complain about something or the other, like they feel everything is dim, whatever it is. So it is important to use pilocarpine when you are planning for a YAG peripheral iridotomy, where you want really stretch out the iris so that iris becomes thinner and you can start seeing the crypts better to do the YAG-PI much easier. So, but then you have this problem of severe headache and also other associated problems, and also availability of the pilocarpine only from, I'm not sure whether I can say the trade name. The pilocarp from FDC is good, but some of the other pilocarpines doesn't constrict the pupil as good as what you see. So once you have the crypts like this in your slit lamp examination, is it really you want to constrict the pupil using the pilocarpine? Many times you really may not be doing that or may not be really requiring to do that so. But then definitely yes, we have to constrict. But then you see this, all of us know there is a consensual reflex. When you show the light in one eye, the other eye also goes in for constriction. But what is the problem? See here, the light is shown, direct light, but there is a ill-sustained pupil. So you really may not be able to do a proper iridotomy when the pupil is ill-sustained. But instead, you go and put the torchlight in the other eye, the pupil goes for a constricted position nicely. So you keep showing the light in the other eye, then pupil will be really constricted well. This is instead of 2 millimeters, it will be around, instead of 1.5, it may be around 2 millimeter, but it is enough for you to really see the crypts and do the York peripheral iridotomy without usage of pilocarpine. It is one of the most simplest thing which you can do. The second part is, I'll just show you this again. All of you know this blue light. The blue wavelength light is picked up by something called as there are different RGCs, retinal ganglion cells. There is something called as a IPRGC, that is called as the intrinsically photosensitive retinal ganglion cells. These IPRGCs picks up the blue light specifically at the 475 nanometers. So the advantage of this blue light is once it is shown, it constricts the pupil and sustains it more than what you show with your white light. So I'll just show you the video here. So this is the white light, and then you can see this is the regular white light. You can see the pupil is getting constricted. The other eye also you can see the consensual is working. But then you see I will be showing the blue light. See, when the blue light is shown, the pupil really goes in for a nice 1.5 mm constriction, and also it sustains longer. That is the action of IPRGC over the blue light. So it sustains for quite some time till you complete your York peripheral iridotomy. So there is nothing much more to show that. So I have put in a small blue light illuminator over the slit lamp. It's just like a regular clip where we hang our clothes. Just put the clip in your slit lamp. Today we have all these LED lights, very easily available, very cheap, 1,000 rupees, 1,500 rupees, it is available. You just put and show this, and then it is very easy. You can see the pupil is completely small. So I thought I'll just share this video because this is a very practically, and most of the time it is done by most of the doctors. So I thought it may be useful for you. Thank you.
Thank you, Satyan sir. Such innovations are what makes the ordinary person different from the extraordinary.
Anything specific?
Yeah, one question. Is the blue light more comfortable to the patient than white light, or is it all the same?
It is not comfortable, first of all. Only thing is, if you are going to buy more luminance, for example, this particular light, my staff was complaining about, it is more heat generating because it was more close to the eyes, but you can keep it little away also. So that is not a problem. Blue light is not very uncomfortable. It is something like a dark. The white light is much more uncomfortable than the blue light, and it sustains for longer duration because of the IPRGC activity. So that is very interesting actually. Recently we are doing the study now on the IPRGC, which is having lot of effects. Especially all our circadian rhythm is completely controlled by the IPRGC. So if the IPRGC is not working properly, so there is if you just go through the publications, when the IPRGCs are not there, what really happens is patient goes in for obesity with lot of gastrointestinal problems, anxiety, depression. So there's a nice article on that where you don't have the IPRGC, patients how they go through, and how you treat is giving them the melatonin. for the circadian rhythm. There's very interesting articles are there. So it's nice to see how the IP RGCs are working. Thank you.
Post VR surgery, shallow AC, does it work? Your concentral reflex with the light in the other eye.
You're talking about constriction of the pupil, or
Yeah,
what exactly you mean
many
by?
a time you have this post VR surgery patients going for shallow AC and raised IOP, and you do a YAG-PI.
Right. You're okay.
In such cases, does it work? Because the patient might have used cycloplegic for a long time. We have stopped it a couple of days back, but they have used it for a long time, and the pupil is sort of unresponsive.
See, once the pupil is not having any adhesions, and once the consensual is really working, it should work without any problems. But having said that, I haven't tried on this kind of cases. But once there is no sinic A, then it should really work. There is no change in that. So it's a pupillary pathway anyway. The pupillary pathway, the light reflex is again completely controlled by the IPRGC.
Yeah. Okay, thank you. Any questions from the floor? Thank you, Satyan sir. From here, we move on to Dr. Jason. Dr. Jason is a leading phacosurgeon from Kannur. He'll talk to us on bimanual technique for managing the nucleus in the anterior vitreous phase.
Good morning. As you know, posterior capsular rupture with nucleus retained in the eye is one of the most stressful complications for cataract surgeon. Posterior assisted levitation is a technique to handle nucleus when it is in the anterior vitreous phase. This technique is tailored for anterior segment surgeons. A metal spatula is inserted through pars plana sclerotomy to gently lift the nucleus forward. Pars plana route provides better angle for approaching the posterior surface of the lens. However, the PAL technique has some limitations. Anterior segment surgeons are not familiar with the pars plana route. The procedure is partially blind, and it is a single-handed technique. So, to overcome these limitations, I am describing an alternative technique which is through limbus. This particular capsulotomy is small, so I am making a double rhexis to enlarge the capsular rhexis. Two Sinskey hooks are then inserted through separate limbal incisions. Sinskey hooks act like chopsticks to hold and elevate the nucleus. This technique offers the following advantages. It is a familiar route for anterior segment surgeon, the limbal route. Instruments are introduced from above. It is allowing a direct visualization of the procedure. The technique is bimanual, providing a greater control and precision. And use this technique only when the nucleus is in the anterior vitreous phase. Technique is not ideal when vitreous is present in front of the lens. This is because of the risk of vitreous traction during nuclear elevation. Once the nucleus is in the anterior chamber, you can extract the nucleus using sandwich technique. Do an anterior vitrectomy. Clear the cortex and place the IOL in the sulcus, making an optic catcher for the optics. Retina evaluation should be done at the end of the surgery and during follow-up. Look for any cortex or nucleus fragments left behind. Also see any retinal breaks or any other complications. This alternative limbal-based technique provides a safer and more controlled solution for managing nucleus in the anterior vitreous, ensuring better outcome for patients in resource-limited centers. In this second video, I am showing extraction of a nucleus fragment into the anterior chamber. Thank you.
Thank you, Jason. Jason used to be my competitor for IOLs when we were doing together. So thank you, Jason, for the wonderful video. Is that you do it in every, like most of the cases when you have a PCR problem, or is it only certain cases you advise this because your hands are different, and how easy you feel that everybody can just try this?
Actually, I don't use this technique regularly. I go through pars plana. Pars plana anterior vitrectomy, do anterior vitrectomy through pars plana. The same probe, you can lift the nucleus up.
Okay. So you feel this is a little bit more safer than the one which you go through the pars plana?
This may be because some surgeons I have seen they are not comfortable in going through pars plana. For those people who are hesitant to go through pars plana, maybe this technique may be ideal.
Yeah, I think definitely most of us are used to the anterior route. So it looks quite comfortable to go through this and then avoid major complications. Wonderful. Thank you, Jason.
Jason, most of the anterior segment surgeons, for them, pars plana is an unfamiliar territory.
Yeah.
So at what stage would you say it's safe to go for your technique, and at what stage you should hand over to the VR surgeon?
I think once the nucleus is not seen in the pupillary area, you can leave it for a posterior segment surgeon.
Yeah.
If it is in the anterior segment surgeon, I think it's a common area. If it is in the pupillary area, I don't think you have to leave it for a posterior segment surgeon. You can stabilize the nucleus using viscoelastic, do a vitrectomy, anterior vitrectomy, and lift the nucleus up. Even posterior segment surgeon, what they do is they drop the nucleus completely down first. Then they will, that is the, you don't have to drop it like that, I think. You can yourself handle it.
It's not dropping, it's clearing the vitreous.
Yeah, see, we try to avoid giving it to Dr. Thomas as much as possible. That's the ultimate goal for us.
Thank you, Jason. In your hands, everything looks simple. Thank you.
Thank you.
Now we have Dr. Marian Pauli. She is a senior oculoplastic surgeon from Giridhara Institute, Cochin. Marian will speak to us on differential techniques, refined results.
Yeah, good morning. I thank Dr. Thomas Cherian sir for this opportunity. So I thought I'll just put a few cases across. So first is in the ptosis, what I did differently. So everybody's speaking about MICS, MIVS and MIGS. So for us, it is ptosis, that is minimal incision, levator advancement, that is MILA. So this is a small video. Here the only difference is we are just making a small incision only. It's audience in
marking done. Traction sutures taken. An 8mm lid, crease incision done with the help of radiofrequency cautery. Orbicularis dissection is done. Suborbicularis dissection carried out in preseptal and pretarsal plane. Minimal pretarsal orbicularis is excised. Orbital septum is opened and retracted. LPS aponeurosis identified and sutured to the tarsus with non-absorbable single box suture with 6-0 proline after adjusting the lid height.
This is here we are taking only one suture. Usually in levator advancement we take 3 sutures and we form the lid crease. So now look at this patient. She is 84-year-old, underwent bilateral cataract surgery, and she had all the complaints: irritation, watering, she can't read. So she was actually in fact blaming our cataract surgeon for doing the surgery. So if you look at very carefully, you can there is a frontalis overaction. And look at her middle canthus. Upper punctum is in close opposition to the lower punctum, especially in the right eye. So she had punctal opposition syndrome, that is called functional NLDO, where actually there is no anatomical block, but she is symptomatic because of her opposition of the punctum. So she had ptosis both eyes. So if I operate only one eye, she will get a drooping in the left eye. Again, she will blame me. So I operated both eyes with the minimal incision levator advancement, and this is the post-operative result. And this is very fast, and you will finish both eyes in 15-20 minutes. And she became asymptomatic. So similarly, we can do this in very select number of cases where the lid is very thin and gives you very good result. So now coming to facial palsy. So facial palsy, there are 2 types of procedures: static procedures and dynamic procedures. Static procedures, it helps in eyelid closure like tassorrhaphy, medial canthoplasty, lateral canthoplasty. You can load the lid with the gold, etc. But it will not give any dynamicity to the lid because orbicularis is still paralyzed. And so whereas in dynamic procedures, it helps in the eyelid blink as well as an improvement of lag of-ophthalmos. So in 2019, I operated this patient with left facial palsy with levator recession and lower lid retractor release. So after 5 years, again you can see the same, because I have not addressed her dynamic problems. So here what I did was I transferred the normal orbicularis from the normal side to the paralyzed side. That is called orbicularis oculi muscle transfer. It gives dynamicity to the lid. I'm just skipping the video. This is a very dynamic procedure. You can lift the orbicularis from the normal eye and transfer to the abnormal eye through a tunnel over the nose and suture it to the paralyzed orbicularis. So now I have done orbicularis oculi muscle transfer for her, and this is a post-operative result with improvement in lag of-ophthalmos, and she is asymptomatic in terms of watering because orbicularis pump has come back. So so what I have done differently is nowadays I'm combining both static and dynamic procedures. So this is post-schwannoma excision, right facial palsy. I did raw lift retractor release, lateral canthoplasty. He had ectropion. I did a small skin graft also to increase the anterior lamella combined with orbicularis oculi muscle transfer, and he did well at 1 year follow. Even the blink also has been improved. So even we have documented this with blink rate analysis using LipiView. The blink has improved. The third thing is like facial specific implants in orbital reconstruction. So the routine thing is to put the plate and screws and correct the original bone defect. So now with the 3D printing technology, we can get patient specific implants. So he is, you can see a depressed fracture involving the frontal bone, and eye is phthisis with the third nerve palsy, total ptosis. So with this 3D model, you can see this depression is created, and we made an implant, and it has been incorporated to the patient. So it gives more accuracy to your reconstruction and gives very good cosmetic results also. Thank you.
Because I have no idea.
Thank you, Marian. How do you titrate how much of the transfer you have to do in this lag of ophthalmos?
That is actually blind, because the aim is to transfer the normal orbicularis to the paralyzed orbicularis. The assumption is new motor neurons are coming up. So we are just awaiting the neuromuscular studies to see the nerve conduction. Anyway, blink is coming. So blink can come either mechanical effect also, because when the right orbicularis is functioning, the same orbicularis is functioning in the left also. So there is a blind procedure. There is no titration. Only thing, don't take too much of orbicularis from the other side. Little bit of pretarsal and more of preseptal orbicularis, because pretarsal orbicularis, especially muscle of Riolan, helps in more blink. So.
And is there an option for a resurgery if it's inadequate?
I have got only 1.5 years follow-up now, the first patient. So that I have to see after 10 years.
That's quite interesting actually. It's nice to see that it's working.
Yeah, it's now even patients are very happy because orbicularis pump started functioning, so there is no watering. Most of the patients are not really bothered about the lag of thalamus, but they are worried about the surface problems like irritation, watering, etc. That is improving.
Yeah,
So,
especially that 84 has become 48. Yeah. Thank you, madam.
thank you.
Thank you.
We have our Dr. Thomas to talk to us on can opener ILM peel. I don't know why they also wanted to do the can opener. Over to you. Thank
I'll
you.
explain. Thank you, Dr. Satyan. In fact, this was the technique which I had to develop out of frustration. I usually keep my macular holes towards the noon time. I start off with my regardis, then diabetics, then I go for my macular holes. That's my practice, that's all. One day I finished all my morning cases, the regardis went off fine, the diabetic was okay. And when I was trying to catch the ILM in my macular hole, I was not able to do it. I had a fine tremor. So I tried for some time, then I closed. Frustrated I went. But then 1 or 2 weeks nothing happened. Then again the same thing recurred and I was trying to figure out why this happened. And then I got the reason. I had taken a bronchodilator on the previous evening and I was developing fine tremors. So I was not able to catch the ILM. Then I thought, I've been after these ILMs for quite a long time and should not let this ILM rule me. So I devised this. I tried this. I didn't devise it. Of course, I tried this technique. Yeah, that's how you induce a posterior vitreous detachment with the help of triamcinolone. All that has come off. And then you inject your brilliant blue green, stain it, and then I put multiple nicks in that stained area around. Multiple nicks, just like how you do it on the anterior capsule for a can opener capsulotomy. So multiple nicks, and then I joined a couple of those nicks. So at multiple points to pick up, not just one point after you put your first nick, or if you pinch and peel, you don't have even that one single point. Here I had multiple points to pick up. Here also you see I am having a fine tremor there, but I could overcome that tremor and pick up the ALM. Yeah, after that you do your fluid air exchange and air gas exchange as usual and close, and you have your macular hole closed. So that's why I said this was a technique which was devised out of compulsion and not for anything else. Thank you.
Thank you so much, Dr. Thomas. Wonderful actually. Problem is always should be there for us to innovate something new. So I think it is so nice. Probably for your Tremors, you should have taken a propranolol. That could have been easier. And definitely this looks very nice. The can opener with the continuous curvilinear also is there actually. Both you have combined together. Thank you so much.
And
It looks so
later
nice.
on, I revised it because the first few cases I did that can opener all round. But then I thought it's not good to do that can opener over the papillomacular bundle. So I started doing a semi can opener. That's almost a 270 degree. And then you come back over the papillomacular bundle, you just peel once.
Something similar to a double Rex is kind of.
So
Kind of
that was a modification which I adopted later on.
Yeah, it looks nice actually. Thank you. Because I have no idea about this stuff. So I think somebody who has better knowledge than me can ask some interesting questions on this. Madam, you have anything? Anybody in the participants or in the audience can ask some interesting questions if you have. Because I thought this is a very important and interesting session actually, because it's all very practical and where you can go back and practice these things. Very simple, small tips as a take home is very, I thought it is one of the most important sessions I thought. Thank you. And really thanks for calling me for this particular session actually.
Thank you, and I thank all the speakers for giving up their innovative surgical techniques, showing their innovative surgical techniques here. And thank all the audience for being here today. Thank you. Since we have one speaker less, we are winding ahead of time.